Doctor, we are live now.
Yeah. Okay, thank you. Dear friends, on behalf of Tamil Nadu Ophthalmic Association, I extend a warm welcome to this webinar on cataract surgical training. All of you know very well that cataract is the bread and butter for all of us. So this training program is there in all the teaching institutions and also in other big setup of hospitals. And there are so many ways of training our juniors in cataract surgery. Either you just give them cadaver eye or goat's eye, or now most of the institutions, they have a wet lab, a Paka setup with similar to operation theater, where we have a microscope or a Paco machine. And exactly, but we'll be operating on the cadaver eye or goat's eye. But still, there are so much of advances in the field of surgical training. That's one recent thing is the simulation. This is almost doing surgery in living subject. The type of feeling you will have when you operate in such a system. And for the past few years, it's becoming more popular all over India and also in our country. In our country, I'm very happy to introduce our today's speaker, Dr. Atik Ashish Bachao, who is well known in this field of simulation training. He is the regional director for the LPC in India, and he has done a lot of work along with the LPC people from Netherlands. And I'm also in this juncture, I'm very happy that Sivakumar also was part of the initial this LPC, this program. It's a very good tool to learn surgical steps. And as Bachao, I'm again very happy that he is our own alumni of Tirunelveli Arundhai Hospital. He has done his DNB there, and he has done his cornea fellowship. He's a wonderful surgeon, wonderful person, I can say, wonderful. And also his wife, also from our alumni, Tirunelveli, is orbital oculoplasty surgeon. They are having their own setup in Mumbai. They are doing very well. Apart from this, he is very, very active in this training program. And also, I'm very happy to welcome our President-elect, Dr. Nirmal, and our Secretary, Dr. Siram Kobal, ARC Chairman, Dr. Atik, and MC members, Saravaran, Sharmila, and Madhura Kopar, and Ravi. And of course, I am very, very happy to have a speaker of the day, Dr. Sivakumar, along with Dr. Ashish Bachao. He is going to give his own experience because he is also one of the very, I can say, so many people, they like him to be trained. They like to be trained by Sivakumar. Whether it's a national or international fellows, they very like him very much. And he is there for more than 20, 25 years of experience in surgical training. And he will share his experience. And of course, the third speaker is Sangaranandan. He is taking care of this training program of the similar training in Arvind Madurai. He has got a lot of experience and he has gone to many places and he is also training many people in this. And of course, the panelists, Dr. Venkatesh and Dr. again Atik, and they are having very good experience in surgical training. I'm really happy that this program will be more useful for especially postgraduates and fellows and junior ophthalmologists to update their knowledge and also help them to where to go for training and how to use it. There's so many things are there. That's why I thought I can have this program today. With this, I once again welcome all of you. Before going to the main session, I would like to invite Dr. Nirmal to say a few words before starting this session. Nirmal.
Thank you, President. Am I audible?
Yeah. Yes, Nirmal. Yes.
Thank you, President, Treasurer, ARC Chairman, Secretary, and all the MC members, and the panelists, Dr. Venkatesh, Dr. Vivekanandan. Venkatesh is indeed a very good FECO trainer. I've seen many of his wonderful videos. And the speakers, Ashish, Shivkumar, and Shankaranandan. It's indeed a wonderful topic, sir. There's always so much to learn in cataract surgery. Even after so many years, every case is a learning experience. I'm sure all these experienced people will share their inputs for the benefit of the youngsters. And it's always there is a gap that is between the academic community when they come out of the postgraduate and fellowship and the real practice scenario. So one gap they feel is the gap in the practical surgical training, and they've not had enough surgical experience. That is the feedback of every youngsters today. Yes, there are very good institutions. Yes, there are very good practical sessions in many institutions, but there's always a doubt in the mind of the postgraduate and fellow when they come out of the college or institution. And as it goes, simulation indeed welcome training part, because we are getting less and less patient experience, hands-on experience. And with good simulation training, I'm sure this number of patients we deal with in the initial phase should come down, so that we'll be able to give quality care as well as good outcome to all our patients. So this is really a welcome topic. I'm sure it will be a good learning experience for not only the youngsters, but also the trainers among us. So I'm eagerly waiting to listen to the simulation-based talk and the training by the maestros. Thank you, RK sir, for arranging this. And I also invite all of you to Trichy, TriCon 2023. The organizing committee is working in full swing. So join us, register and join us for the 70th annual conference of TNOA, scheduled from 4th to 6th of August next month at Trichy. So thank you, sir, and welcome all of you.
Welcome, Madhusegar. Madhusegar is a wonderful phaco surgeon from Aravind Madurai, and he's the head of the cataract and refractive surgery at Madurai.
Thank you, sir.
Welcome, Madhusegar, and also I welcome Dr. Vivek. He's joining from Sitapur. Now he's in Sitapur in UP. Ram, you want to say a few words? Ram Latik.
Nothing great, sir. I think Dr. Nirmal
told
what I wanted to say, invited everybody for the conference. The only other thought, which I probably thought I will ask in the end of the session, but in case I forget, I'll ask now, is whether there was any possibility of using such simulators instead of wet labs in conferences. And TriCon can be a starting point.
Okay. That's great.
Let's hopefully let us see whether it's possible.
I think some companies have this access to simulation machines already. So there are people who are using that day in and out. I think it should come from them.
Yeah, hopefully.
We'll definitely welcome them.
Okay. I think you have anything to say?
Sir, we'll start the session, sir. I think already we are...
Very good, yeah. Now I hand over the mic to Dr. Sivakumar.
Thank you very much, sir, and I hope that my screen is visible, my slides are visible.
Yes, yeah.
Thank you very much, sir, for this opportunity to present in a very unique webinar. I'll be talking about the current cataract surgical training status and where we stand. So we know my slide is not moving. So I'm sorry for this small delay. So we know that cataract is one of the leading causes for reversible or treatable blindness. And so it is expected that when one comes out of the ophthalmology training, he should be capable of handling this particular problem. So the aim of ophthalmic residency program is to impart an expertise in handling two of the main causes of avoidable blindness and impairment, visual impairment, and that is refractive errors and cataract. So basically, like Sir said, cataract is a bread and butter for an ophthalmologist. So a person who calls himself an ophthalmologist should actually be considered to be good in cataract surgery. But then a reality check shows that the residency program leaves quite a lot to be desired. It may not be measuring up to the standards and deliver these goals. So like a reality check was done around the turn of the century. The AIOS through its ARC arm from 2000 conducted surveys in various regions in the medical colleges and residency programs. And many of the publications from which I have taken my presentation are from these surveys, and I have quoted them below. So what it found was that there was a big number in the big gap in the number of cataract surgeries which a resident considered as ideal and what they had done. So basically, the residents felt that they did not have enough during their surgical training. Also, what was found was that the cataract training standards were hugely variable. Some institutes could give them a lot of exposure, while some could not give them an independent exposure due to various reasons. Also, most of the colleges exclusively focused on ECC and later on in SICS, and that too was a little insufficient in many of the cases. And more than 50% residents had not performed independently any extracapsular cataract extraction, and it was not long back. It was a survey done in about 2015. In another survey, it was found that more than 50% residents had not performed more than one phaco. Phaco today is the procedure of choice for any cataract surgery, but then when it comes to training, probably phaco isn't at the top of the list. And not more than 50% residents, had not done more than one phaco or any other extraocular surgery, including deletion. The trend over time between the 20th century and the 21st century was compared. And the 20th century were respondents were from 1967 to 2002. And very naturally, the focus was then on extracapsular cataract extraction, with the median being 43. And in the 21st century, the median was for SICS, the most common surgery was 55. But interestingly, if you go to see the average mean done by the residents during both eras, were almost similar at about 108, a mean of 108, with the mean being more in SICS in the 21st century and ECC being more in the 20th century. And when it came to phaco, in spite of phaco holding center stage today, the mean was 0 and 1, and the mean was almost similar. So what are the roadblocks during the residency? Basically, there's a hierarchical system where the consultants and the associates, professors, assistant professors and all get to do the cases earlier because they are more important cases, more difficult cases, and the residents get the cases which are at the end of the theater. Also, they are probably handed out some suboptimal instruments and equipments because there's quite a bit of, in the government setup at least, there's quite a bit of red tapeism and bureaucracy. And there will be lack of maintenance, difficulty in procuring equipments. The professors, assistant professors would be very wary of giving them good equipments because if something goes wrong, it is difficult to put it right. The surgeries may actually come to a stop. The patients will be put to inconvenience. So there are various reasons why probably the residents may not get the optimum instruments or equipments. The support staff and assistants too may have less expertise or inclination. The more expert assisting nurses going away for more important work like sterilization, finishing up the day's work. Then there is always this paradox about the low volume and high volume. Whenever there is a low volume, there's a lack of patients and the residents may not have enough number of patients to operate. And the high volume paradox is that there is a lack of time and the list has to be finished and there may not be enough time spent by a consultant or a trainer in training the resident. So what is needed? What is needed is a surgical and clinical training taking center stage and being seen as the core of the residency program. Today, our focus is more on the theoretical aspects and about presenting cases and diagnosis, but it should also be in practically handling cases, both medically as well as surgically. Surgical competence should be a part of evaluation, and this is today easy. For the last decade, the rubrics have been developed. The Oscar scores for the different surgeries, so like SICS and FECO have been developed. So it's very easy to objectively compare surgical competence. And this should actually form part of a 360-degree evaluation of a resident, not only a theoretical evaluation, which is usually the hallmark now of a resident coming out of the residency program. There should be enough funds available to buy and to maintain these instruments and equipments, and maybe even training of personnel within the hospitals to troubleshoot small problems, so that they are not dependent on the service engineers or big companies to come and correct the equipment, especially in the government setup. More importantly, there needs to be a training of trainers. Imparting surgical skill is beyond just didactic lectures or supervising a particular surgical case. It involves getting into the psyche of the resident to know what he fears, to know what are his stumbling blocks in learning, and solving those problems so that he can learn better. And then, of course, the residency program needs a well-equipped wet lab. And in the wet lab, what should be the facilities? There should be availability of animal and cadaver dyes. And if suppose we do have these simulators, then it's always a welcome improvement onto the wet lab. And basically, there may be a day, maybe a decade or two later, where simulators are the only things available in the wet labs. Ready-made kits like Cataract, dry wet lab, and dry and wet lab kits are available for FECO. These can be made available even if simulators are not available. And there are innovative ways to perform various steps with household items, like the sponges for suturing, the lemon can be used for trying out tunnel making. The tomato, which is just boiled for about 10 seconds, the loose skin can be used for capsulexis. Grapes can be used for capsulexis. The orbital silicone implant can be used for practicing tunneling. So these are all some of the innovative ways in which you can use some of the household items for wet lab practice. Now, it is not only the trainees, but also the trainers who felt this deficiency in cataract surgical training. And when the trainers were asked in 1920, just about 4 years back, they felt that the residents should do at least 50 SICS. The median was about 50, with the interquartile range from 40 to 100. And FECO also has 50, between interquartile range being between 20 and 60. But then again, there was a significant variation among the teachers on the number of independent surgeries to be done by a resident. There are variations, from area to area. So essentially, what happens after a resident comes out of the postgraduate program? So then they have to find various other avenues to further the surgical skills. So if they have got a certain number of cases behind them, it's a hospital which has given them a good number of independent cases, then they do risk taking up jobs in charitable hospitals where they can practice on their surgery. They can go ahead and learn surgery by themselves, and mostly it's largely they are self-learned. And in the last 2 decades, there have been a lot of institutes who have come up with short-term cataract surgical programs in SICS and more so in FECO. And we have got a lot of these centers blossoming in the south and in the west of the country. And these have gone a long way in training many of these who have got, who want to spend less time on their cataract, honing their cataract skills, and get this opportunity through this short-term training program. Leading institutes offer long-term fellowship programs in various anterior segment subspecialties. And during that, they give some cataract experience. Of course, this is variable. But there are some institutes who also include a certain period of cataract and IOL training prior to starting their particular anterior segment specialty, because we all know that a good background in cataract surgery, a good skill in cataract surgery goes a long way in doing the anterior segment surgeries well. Apart from this, for those who have got very limited exposure to cataract surgical training, most of the institutes also have a structured IOL or FECO fellowship programs for 1 year or 1.5 to 2 years. Now, all this was going on, and then finally COVID-19 struck. This was a tragedy which unfolded. It brought in a lockdown complete for 2 months and then partial lasting for almost 6 months. And during the total lockdown, there was a complete stoppage of all planned surgeries, especially cataract. Regular outpatient flow had stopped in the total lockdown period. And added to that, about 1/3 of the residents were posted in the COVID duties. And even during restart, there was a poor inflow of patients because of poor transport and probably due to more pressing medical needs. So the residents were left with very few patients to operate upon. Also because community outreach, which is the biggest source for these patients, was not possible for long during the recovery period. Now, when a survey was taken about the effect of this on the residency and fellowship programs, out of 716 who responded, 95% were in the residency programs, and a quarter of them were posted for COVID duties. And among the clinical training and the surgical training, theoretical training, 80% overwhelmingly felt that the surgical training was negatively impacted. So this was the biggest effect of COVID on the surgical training. But of course, every dark cloud comes with a silver lining, and COVID brought with it certain benefits. It increased the importance and the reliance on wet lab for training. So there was a return of the residents for surgical training to the wet lab. And every institute engaged the residents by setting up a really committed and structured program in the wet lab for training their residents when patients were not available. There was also a search for innovative techniques, materials, and devices. These intensified, and some of the older ones were also adopted widely. So it was known that you could practice on these things, but then it wasn't used then. But now there was a certain forcing of the hand, and therefore this had to be done. One of the biggest offshoots was the large number of webinars and surginars, which became sources of increasing knowledge. And the simulator, especially the MSICS simulator, which made its entry around 2017, added value to the training, especially when there was a dearth of real patients. And we can see through the various publications during the COVID period that there was an increased accent on the wet lab, the use of wet lab, how was the effect on surgical training because of wet lab. And of course, there were a lot of articles on simulators, and we have two of the authors here who are going to talk about the simulation. And this has really sort of changed the way a resident can train in surgery, so that when he really operates on a patient, he needs fewer patients to gain that confidence and the expertise. Apart from this, the other silver lining was that prominent surgeons with a passion and flair for teaching, institutions and ophthalmic societies like regional ophthalmic societies like TNOA, iOS, all of them took to the internet platforms and social media, had their own channels in the YouTube, and they posted their surgeonars, webinars, and even instruction videos on surgeries. Apart from this, in an informal way, surgical videos and tips and discussions happened with inputs from renowned surgeons in social media chat groups like WhatsApp and Telegram. Even today, ocular surgery worldwide, eye surgery worldwide on Telegram carries discussions of about 10 clips put in per day. And there is really a very rich source of learning for not only residents, but all of us also. Telementoring was also tried in a few institutions. Of note was Arvind Pondicherry, where a senior surgeon operated and the juniors watched over Facebook Live, or a junior operated and the senior instructed on Facebook Live. So telementoring was tried, and probably this could be the future also. And so the best part of all this is that these unconventional modalities are here to stay and may even be the future of surgical training. So where are we today? So when we look at the post-COVID status in 2022, this is a paper by Dr. Akshay Nair, who is also into the Help Me See program. A survey of 740 residents showed that only 40% were doing independent surgeries. And of those who were not doing independent surgeries, almost 2/3 were in their final year. And 97% were exposed to SICS, and only 14% were exposed to phaco, which is probably the procedure of choice today for all surgeries. And they should know phaco. And only about one third had performed less than 100 surgeries. So while all this may look a little pessimistic, there is a lot of scope for optimism, because we are now aware of this as a problem. There's a rising awareness over the last 2 decades. A lot of changes have taken place also in the training programs. And now with COVID, out of the negatives, we have got a positive, where more avenues have been opened up. Now we have got the simulator, which is probably a very valuable tool in surgical training. So with all these, probably we should be a bit more optimistic about imparting really good surgical training right at the start, when we have the budding surgeon in the residency program. And there needs to be a concerted approach with the setting up and adoption of a national curriculum, stipulating the number of surgeries to be done in post-graduation in order to produce competent surgeons. Thank you very much, sir.
Really, it's a wonderful talk, Sivakumar.
Thank you, sir. Thank you.
From given an overview of surgical training and what is the past and present and future. Really, it's an eye-opener for most of the things we didn't know. Because when we were PGs, at that time, we didn't have this type of structured surgical training at that time, about 35, 40 years back. And usually we used to see the seniors doing surgery, and then we will be allowed to do in steps, then they will be doing independent surgery. But now you have a very structured, almost like a spoon fed for the postgraduates and fellows. It is nice. And we will have a discussion at the end of the panel, at the end of the all three talk. Now I invite Dr. Bachcha to give his talk.
Thank you, sir.
Thank you, Bachcha, for accepting our request. It's really very happy. It's, as always, you are a wonderful person. Yeah. Yes, Bachcha.
At the outset, thank you, Dr. RK, sir. At the outset, I would like to thank the Tamil Nadu Ophthalmic Association for having me here and giving me this opportunity. I feel humbled to be amongst the very same surgeons who have started surgery for me, Dr. RK sir and Shivkumar sir, right in the picture. I am a consultant with Help Me See in simulation development and training. The Help Me See Eye Surgery Simulator is a virtual reality haptic feedback based simulator, which has the unique identity where it has a tactile feedback and it mimics a real life surgical scenario. So there is the setup which talks about having the eyepieces measurement, the vertical adjustment, and 2 unique handpieces, which we call as haptics, which can mimic and can be used to mimic any instrument which we use. Like it can we can make it used for a crescent or a keratome or even a phaco probe right now. With the plunger on the right one, we can use it for a syringe. If you see, there is a hollow, there is nothing inside, but with the use of AI, this is what you see through the microscope, wherein a real lifelike eye is simulated on the globe. It not just looks real, it also feels real. This is what we call tactile feedback. The tissue responds to you just like a normal sclera or normal cornea or even a capsular rhexis scenario would reflect. The tactile feedback is what makes the Help Me See eye surgery simulator stand apart and above all the other simulators available right now. It is actually the only simulator available which has this unique feature. Shiv Kumar sir touched on the impact of COVID-19, which led to less training opportunities globally, which led to increased risk to patients because the eyes available for training were less. In the end, we had only COVID specialists as ophthalmologists coming out and graduating without any surgical background. This in turn made less confident surgeons, and the growing cataract backlog in developing countries like India continued to grow. This is exactly where the Help Me See eye surgery simulator and the simulation-based structured training which we offer is bridging the gap. We have installed the simulator everywhere in Arvind and LV Prasad, and it is showing that it is able to bridge that gap, bring down surgical complications, increase the competency of training through its unique feature, which is the haptic tactile feedback, which gives it the uniqueness in its high fidelity and 3D virtual reality intuitive software. Currently, we have many courses that we offer. These courses are what we call as the simulation-based training courses. These are structured courses run at partner institutes at the Help Me See Center of Excellence in Mumbai as well. We take pride in having these courses as being instructor-led, a qualified ophthalmologist who takes you through all the training scenarios. Help Me See has developed its ebook, and as we speak, we are also going to have a phaco ebook in collaboration with Arvind Eye Hospital, Madurai. There are dedicated classroom sessions, and in the end, after the course is finished, there is evaluation, which is both subjective and objective, which is reflected in the performance of the students. Currently, we are having the M6, which is manual small incision cataract surgery course. In addition to that, we have courses like complications management, wherein these are short courses. We train people to do management of rigid pupil sphincterotomies or management of surgical aphakia in instances where you can use ACL insertions. We're also having sphincterotomy, insertion of CTR. There is a course which is having suturing, very recently developed and more pronounced, and recently which we developed is phaco. I'll take you through what is our flagship and the most popular SICS course. This involves right from making the incision, whether you want to make a straight or a frown incision, followed by tunnel dissection. The uniqueness of the simulator is that it has something called as a guiding tools. You can see that there is an IOP indicator which guides the trainee to tell whether they're pressing too much on the globe and they need to release the pressure, or there might be rise in pressure. There is real-time depiction of the depth of the crescent by the depth tool, and it also guides us to know how much should be the extent of the tunnel, whether it's too wide or whether it's too short, how much is the extent where we need to enter with the keratome or make a side port incision. As you see, there are these angle guiding tools which guide the trainee to correctly hold the instrument and the angle that with which it should enter the anterior chamber. So goes for injection of viscoelastic. The depth tool tells real time the position of the tip of the cannula so that you don't end up touching the cornea, or for that matter the anterior lens capsule. And the keratometry, it's depicted as real life. We feel the first resistance followed by the sudden giveaway, and how to extend it and extend the pocket. So all these are reflected real time on the simulator. The most important step in SICS as well as phaco, the capsular rhexis with the cystitome. We also have a utrata. Whether we want to start with an inverted C or an inverted J or just a straight line and then push it, the simulation is going to support that. How we end up doing capsular axis clock hour by clock hour, then go back to the cut uncut junction closer on the hinge and try and maneuver the axis. Everything is possible. Now, what the simulator also tells you what can go wrong, whether it is a corneal endothelial touch or whether it is an iris touch or simply a axis run out, it catches everything real time. So it tells us in real time whether the attempt was done well or was there anything that needed improvement. So parameters like what was the maximum size of your capsular axis, what was the minimum, did you end up with some complications, all these are rated, which makes the score satisfactory or unsatisfactory. So in a typical training day, a trainee ends up doing almost 70-80 times capsular axis, so that they learn it so much so much so that they learn how to not make it wrong. That's the competency that they achieve in the training program that is run in one of our training centers. So all complications like zonular breakage or whether there was an endothelial touch or contact with iris, all get reported, thereby making the attempt as being satisfactory or unsatisfactory. Steps like hydrodissection, hydrodelineation, or cortical hydration are depicted. You can see a fluid wave passing and lifting of the nucleus. Sometimes we also see a golden ring, exactly like it happens in real life surgery. And then delivering the nucleus, first wheeling it out with a Sinskey hook, and then using an irrigating or a wire vectis to take the nucleus out of the capsular, out of the eye. Also, complications for each attempt are recorded in the performance data. Each attempt is recorded so that you can go back to your instructor and discuss what went wrong for that day in the debrief sessions. So pressure, counter pressure, or just with the wire vectis, how to take the nucleus out are depicted on the Help Me See Eye Surgery simulator. Steps like cortex aspiration, again, you will see some training tools guiding. The training tool on the top guides you real time where to know where is the position of the tip of your Sinskey. You can use right paracentesis also to remove a subincisional cortex. If you end up doing some complications like pulling the capsular bag, it will show and it will alert real time that there was excessive zonular breakage that happened during this session, and anything more than that, like anterior capsular aspiration, gets depicted and alerts the trainee that something went wrong and we need to restart the attempt. So this kind of flexibility it gives for the trainee in a typical training day. We can end up doing 100-150 attempts, and the final step is inserting and dialing a rigid PMML lens. Again, there are training tools which will guide the trainee to know what is the position. Now, in the initial training, we expect them to keep the training tools on, but as they progress and we see their progress, the instructor is comfortable to put the training tools off, much like what we do in real life, so that it becomes a habit, it becomes a part of their skill set, so that it comes at a spinal level to do each surgical step. Now, these trainees, when they graduate to do live mentor training, they have very less complications. We published a few reports, which few of which Dr. Shivkumar also shared, that trainees who underwent simulation-based training did complications 40% less as those who did not do. This is the typical training environment in Help Me See Mumbai Center of Excellence. We have an ebook for self-study, classroom sessions, then activities which involve simulation-based training for almost 3 hours a day, followed by discussion one-on-one with the instructor to know what went wrong, what can be improved, and what do we need to do the next day. Of course, we have moved on to e-learning now. We have e-learning course for the manual small incision cataract surgery platform, wherein the students at their own pace go on the e-learning. They get satisfied, the instructor is satisfied with their performance, and that's when they are graduated to the simulation platform in the Center of Excellence. We are also working right now on anterior vitrectomy, posterior capsular rupture management, implantation of a sulcus fixated lens. We already have training courses on this, like management of surgical aphakia using an anterior chamber intraocular lens, how to insert it, how to position the haptics, how to dial it inside the anterior chamber without causing excessive damage to the cornea or posterior bowing of iris. So the simulation gives this flexibility to keep doing these complications and managing them, because in real life surgical training scenario, we do not have this option of waiting for expecting a complication to happen and then learning on a real patient, because that's not what it is about. So simulation gives us this flexibility to learn on the surgical simulator and continue practicing as much as you want. Like in this instance, management of one quadrant zonular dehiscence using a manual CTR capsular tension ring insertion. Now you also have these guiding tools which tell you the real-time position of the leading as well as the trailing haptic, how to insert the CTR correctly inside, especially the manual one. Now we're also working on an injectable form of a CTR as well. And finally, the last bit where we want to ensure that the trailing eyelet also goes inside the capsular bag, the little handshake technique that happens. Everything is simulated, whether you want to do it through the main incision or whether you want to do it with the side port. And in cases where you have rigid pupil, how to do manage a rigid pupil before you go on to do a capsulorhexis, doing sphincterotomy cuts, whether you want to do 3, then or 4, inject viscoelastic, wait for mydriasis to happen, and then continue doing surgery. Now, all these are also fed into the performance data system, which tells you exactly what you did, what was the pre-operative pupillary diameter, and post-sphincterotomy, how much did you attain. So everything is recorded objectively as well on the simulation platform. Now, the most exciting bit of simulation that we released this year is the suturing. Now, this is something which is Shiv Kumar sir said that it might take a decade, but it's already here. So the future is already here. We are already training on it using the Help Me See Eye Surgery Simulator. For the ease of learning, we have broken down this suturing into 4 important steps. It's like first pass, just training learns just passing the needle, and they do it 25 times or 30 times. To tell them what is the correct depth of entry of the needle in the sclera, the distance from the incision, and things like that. The next is making the knots, whether you do 3-2-1 or 3-1-1, perpendicular, parallel, and again perpendicular, whichever way we want to do. The third is cutting the knot, and the fourth one is burying the incision. Now, once they graduate from all these individual steps, we join them and allow them to continue from passing the needle to tying the knots to cutting and burying them. This has tremendous applications, not just in suturing, but whether you want to do pterygium with sutures. We are working on trabeculectomy where these suturings will be applied. We are also talking of doing management of anterior corneal tear repair with suturing and also keratoplasty. So this gives the extra advantage to the trainee to learn suturing. In a typical training session, the trainee ends up doing almost 25 times or 30 times each one of these, so almost 200 attempts in a day that they do on this, so that they become confident and they know how to maneuver these techniques before they actually touch the live patient. In addition to that, what we have developed right now and will be releasing soon, we showed a glimpse of this in few conferences globally, and this will also be we launched this at the SFO conference in Paris and the All India Ophthalmology Conference in Kochi, is the phacoemulsification simulation. Now, this allows us to do the steps right from the beginning to the end, whether it's making a clear corneal incision, paracentesis, viscoelastic exchange. This is available on the LPC surgical simulation platform. We have introduced a new Utrata forceps, which is the micro forceps, which can be used for the main incision, because the rhexis that we need is a smaller one in phaco that has been taken care of. Hydrodissection, hydrodelineation, again nucleus rotation to remove the attachments of the nucleus have been simulated. These again, there are some performance data that get collected. For the first time, the foot pedal that you see on the right bottom of the screen is something which we have developed on our own by our own people. So that's the Help Me See standard foot pedal that you see. The phaco machine makes exactly the same sounds that is expected or come out of real machines. Right now, we are talking about divide and conquer, so we are able to do the trenches. Real-time machine tells what is the depth of your trench. You need to go more till you see a faint red glow, so that you do the divide, making the trenches and divide it using the probe and the Sinskey hook. This also gets reflected in the performance data. Finally, the next step, which is phaco aspiration of phaco emulsification of the quadrants. The sounds are also the same. The occlusion sound, the phaco emulsification sounds are exactly what a real machine would show. So it shows the exact training environment that we see in OR while training in a simulation based setup. This is the real game changer in cataract surgical training, and HealthPC has been at the forefront of surgical innovation, surgical training in the area of simulation-based cataract surgical training. So steps like cortical aspiration, implantation of a foldable intraocular lens. Again, there are guiding tools which tell us real time if the angle of attack is correct, if the leading haptic is going inside the capsular bag, whether you're dialing it well, did you induce some pressure on the zonules, did you break any zonules? All these get captured in the performance data, thereby giving a weightage to it, making the attempt as being satisfactory or unsatisfactory. So that's what the beauty of simulation that it brings to the table. We can practice until we cannot get it wrong. Once we graduate from simulation-based training to real-life surgical training, the learning curve comes down, the complication rates comes down. So in a high volume setup, the trainer can actually spend more time taking care of that high volumes because he or she is sure that the simulation-based training will take care of the learning curve of the students. So that is what the Help Me See Eye Surgery simulation is bringing to the forefront in technological innovation. We are proud to have simulation-based trainings setups at Arvind Eye Hospital, Madurai, at LV Prasad, and our very own Center of Excellence in Mumbai. We plan to have many such centers. Right now, as we stand, we have trained more than 1,000 cataract surgeons already in Mumbai, and we can't stop. We want to do more. And we are proud to be associated with high volume institutes like Arvind to have to take this number further. Worldwide, we have a lot of presence. Just to name a few, we are in Mexico. We have our own sim lab in New Jersey. We are very soon starting our own center in France through JEPROMED, which is in Strasbourg, France, and a humanitarian project at La Polyclinique, Madagascar. So there is a lot of scope. It's just the beginning. I'm happy to say that we are already talking about the future. It's already here through the Help Me See Eye Surgery simulation platform. We are working on pediatric cataract surgery, open globe injury, trabeculectomy, and discussions about corneal transplantation and refractive surgery. Simulation-based surgical training with the Help Me See Eye Surgery simulation platform is a real game changer in cataract surgical training with its virtual reality haptic feedback system. The training, which is instructor-led, performance parameter reports on each attempt. We can safely say that you can practice until you cannot get it wrong, which will lead to confident surgeons, better skills, better outcomes, happy patients, and happy trainers and happy surgeons. I invite questions, comments, any suggestions, and once again I thank my mentors at Arvind, Dr. RK sir and Dr. Shivkumar sir, for giving me this opportunity and platform to present our work before you. I'm truly humbled to be on this stage presenting to this august audience. Thank you very much.
Thank you, Bachav. Thank you. It's wonderful, really. You have given a nice overview about the simulation-based cataract surgery, because most of us we don't know about the what is the real concept of this simulation-based. But according to it, it looks so nice. It's almost operating on a human eye. You have the same feeling now?
Yes.
Yeah. Thank you very much. We'll have the discussion later at the end. Now I invite Dr. Shankaranathan, who is involved in this simulation-based cataract surgery, and he will share his experience. Dr. Shankar.
Sir, I hope the slide is visible, sir.
Yes, sir.
I thank Arvind Eye System, Help Me See, and TNOA for giving me this opportunity and to be part of the session today. Like all the previous seniors have told us, this is the very first time, to my knowledge, that we are hearing a cataract surgical training webinar in TNOA or any other state level conference. So with this, I would like to start my experience. So as we all know, Arvind Eye Care System, one of the largest eye care providers in the world. We currently, last year, the system had operated around 192,400 surgeries in Arvind Madurai alone. So this number might be large, but the reality is the large number of surgeries were done by junior resident doctors. This number is being done by fellows, residents, and external trainees. Now, why is this number very important in terms of large volume? If you see, we have around 60 postgraduates and close to 40 fellows in our institution. So for them to perform such huge volume numbers, we need to train them in a way that they are able to handle high volume surgeries. Now, in performing high volume surgeries, you need to master your basics steps in SACS properly. In a recent study conducted in our institution, and which has also been published, it was found that in order to decrease the surgical complications, a resident takes close to 300 SACS surgeries to have their complication rate drop down below 2%. So we needed a system that will help us to train the surgeons more effectively, to reduce their intraoperative complications, and when they're good, to also help them handle more complicated cases. These all put together needs to be done in a very short span. So like in traditional wet lab, the available training modules that were there in previous years were the cadaver eye, the Rexis practice in a polyethylene or the IOL box, and tunnel practice using foam sheets. In all these scenarios, the cadaver eye has been the gold standard training module that was available. We have been trained in this module only. But the only difficulty that we had as trainers were that we were never able to assess whether the trainees are doing the tunneling properly, because the tunnel involves three-dimensional approach to it. You need to be in a particular angle, particular depth to get the tunneling correct. So we were unable to assess their performance, and especially the Rexis also, where we need to know what amount of force they put on the capsule, how to prevent the runaway, and all those things we were not able to assess even in the gauze side as well as in the polyethylene films. So the other main challenges that the traditional wet lab had were procurement of these gauze side during the COVID time period, and the multiple usage. Like Dr. Ashish told this very clearly. In a simulator scenario, you can always practice n number of times one particular step. We have surgeons who are practicing tunnels alone for 100 times, 120 times, but this is not possible to do in a gauze side. You need a large amount of gauze side to do that. And another advantage is with a single simulator, we will be able to train quite a large number of doctors in a very short period. And another disadvantage with the traditional method is it is unable to allow the surgeons to practice all steps of SACS. So with this said, Arvind Eye Care System was introduced to simulation-based eye care training in 21st March. And we had the opportunity to be trained by Dr. Ashish himself in Mumbai. This was a very humbling experience because I found it really difficult initially to master my techniques. But once we did it, we found it very, very useful. And after that, we have trained quite a lot of surgeons in Arvind Madurai. Like these are the number of surgeons that were trained in Arvind Madurai. Like, well, we had trained 16 medical officers in our own institution, our own fellows, and our own residents. And people like these external trainees, this is a very interesting number because most of these people didn't know that Arvind had simulation initially. So when they joined us and when they saw our residents and fellows practicing, they voluntarily then joined for this program and they got benefited from it. So in order to prepare our resident trainees and our young fellows to do high volume, these are the groups that we have segregated into, and all these 4 groups are trained in the simulation-based training on these bases. Like the group 1, they are the fresh graduates, like our residents who go through our 1 month training. And then the group 2 are surgeons who have done more than 100 SACS, but still have quite a large amount of complication. And they come back to us, they practice in the simulation lab, and they have showed very, very successful results. And the third one is they are doing volume, but in order to do high volume, like per ton, we have surgeons who are doing 50, 60. Now they are able to do this only because they're able to practice multiple times in the wet lab, even at the end of the day. You don't need anyone to monitor you. The simulator itself monitors you. And with Ashish showing the CTR placement, the sphincterotomy, this has also helped our surgeons manage complex cases also. So this is just a chart that I want to share here. This is one of our module that we trialed out with our medical officers. Before simulated training, you can see the complication rates being in high numbers. And when you see over here, you can see the numbers dropping by. And also you can see the number of volume, the cases have also increased in this group. And I would like to just share this and share one more screen. This is the recent data that we want to share again. This is the pre-simulated training for 3 years. Sorry about the date, but this is for 3 years. Look at the number on the left and the complication rates. But now after they finished their post-graduation, after coming into the simulation program, look at their numbers within 5 months. The number has also jumped and their complication rates have dropped down considerably. So this has encouraged our residents and our fellows, even without inviting them to the wet lab, they come on their own and they practice. So the latest addition in this pipeline is like what Ashish sir told. We have the ability to train our junior colleagues in doing sphincterotomy and CTR implantation. And we also are allowing them to practice the suturing model. Suturing model, initially we used to do it in a foam material, which didn't give the exact depth in which the needle needs to pass. Are we tightening it too much? Are we putting pressure too much on the globe? All these now are being able to be assessed by the trainee itself in the simulator. So the advantages of the simulator is that it doesn't need the cadaver eyeball is now not needed anymore. The surgeons are able to practice all the steps multiple times. That is the very important point. And another thing is the trainer, even the trainer can provide a feedback even when he is not there with this surgeon. For example, the trainer might be in the OPD. He may come back. He can even pay back the training steps that the trainee has done, and then he can give an effective feedback. And another thing is about the ebook. The ebook is a 1,000-page book that is developed by Help Me See Group. It actually has all the entire steps of SICS breakdown into small parts and explained in detail. All the steps have a particular related video also. And what Shivakumar sir told this very clearly, the trainer now, I very confidently we say I have become a good surgeon only because I become a trainer. So once our fellows who are doing these numbers, we make them trainers. They get trained in simulation based training through Mumbai office. And once they're certified as instructors, they start training the younger trainees in the simulation. This helps them also become more confident and consistent in their surgical procedures. Like it is known very well that learning is not a one-stop point. It is a continuous process, and it helps the trainer also become much better. And again, I thank the TNOA, Arundhika System Management, and Help Me See Group for having me part of this simulation training program. Thank you, sir.
Thank you very much, Dr. Sankaranandan, and Dr. Ashish Pacha, of course, for talking about the simulator. I have had the wonderful opportunity to be one among the first 2 people to have tested the simulator at the time when the tunnel program was designed. Now, to put things into perspective, I would just like to give an introduction, probably, which Dr. Bachar did not give. Help Me See has done this in collaboration with the company Moog, which actually designs the simulators for pilots. And just like surgeons, pilots have got absolutely no chance for an error. So that's the level of simulation that they have been able to produce. And LPC wanted that level of feedback and a simulation which would mimic the entire surgery in itself. So you can understand what has gone into this simulator in order to create the situation of like almost doing it in virtual reality. So I would now ask for further discussion on this. And I believe that when I said that it may take a decade, I talked like what FACO developed over a period of time. Now it's like it's become much more economical. So at the day, more institutions can actually go ahead with having a simulator. This is going to go really a step higher, and almost all residents can get a simulator training. So I think that may take probably a decade or maybe less, depending on how fast we embrace technology. So on to the panelists for the discussion, please.
Thank you, sir. Amazing talk by all the three speakers. Well, before getting into this simulator concept, something really significant that Shivakumar sir touched upon was the number of postgraduates at present who don't get any surgical training in few colleges. And at present, the number of colleges and the number of PG seats is drastically increasing. So sir was saying that surgical assessment also should be planned for postgraduates, which is very nice and a great thought that has come. I have my professor with me, Dr. Venkatesh. I was sir student as a MBBS student. So I think that request can be raised or brought forward to the medical council from TNOA itself, so that with these sort of simulators in place, cases are actually not needed. Even assessment can be done on these things. Venkatesh sir, your views on that before we go into the simulator part of discussion, sir.
Yeah, Dr. Ashish and Dr. Shivakumar, excellent presentations. And what I heard today was something that blew my mind. But I have certain skepticism about, simulated training, mostly with respect to the feedback. They said there was a haptic feedback. So is the feedback just in the form of a vibratory impulse, or they actually feel the tension of the tissues? Because I think surgery is all about feel. I mean, even though you can tell them the steps and they move the hands around, the one that really differentiates true surgery from working on a simulation is the tissue resistance, the tactile feedback. If you can actually capture that, then you have given them something significant to work on. Like for instance, like I play golf and I also played the simulator golf, and it is nothing close to the real thing. So I want to know, at least I want to know from the experience of Dr. Shankar and Dr. Shivakumar, who have done the simulator, how close does it feel to the real thing when you work on the simulator?
Sir, to answer your question, absolutely close, sir. Absolutely close. And
that's fantastic.
Yes. At least I can vouch for the part that I tested, tunnel making and the side code. And the first thing that that I was asked to do, I was given a forceps and I was asked to press the eye that I was seeing. Okay, and I pressed it. It was something like an IOP of 30 or something. So, Dr. John Strauss is an instructor who goes around teaching SICS in ships. And he told me, press harder. I said, no, it's an eye. Then he said, that's what we wanted, he said. So that was the very first response that I had. And the entire tunnel making is a real experience in tissue field. And I wanted them to do this for the entire this thing, but I'm not sure because they were running short of time. They have come out with the simulator. But
so how often
again was to go ahead and give that feedback. Before we were taken to this, we were taken to a dental simulation this thing. And there the drilling is absolutely real. They have given this thing in Netherlands. There is a dental college where they do simulation-based cavity filling. That given sensation is absolutely real. So I knew what I was going for, and yet I was surprised with the amount of tactile feedback that it gave. So actually, I even know the way they have built it up. Dr. Haripriya Menon was the person who actually put in was wired up while she was constructing the tunnel for actually measuring the resistance and feedback that went into putting in. So that much of technology has really gone into this simulator. So I think it's a very good simulator as far as the initial parts of MSICS is concerned.
So the tunnel aspect, sir, that is the tunnel aspect, the rexus and the cortex wash. These are the few steps our residents make few common mistakes in. Now that has been drastically reduced, sir. Even the trainers have become more happy now, because initially the trainers will always come and complain the rugged tunnel, the cortex is left behind, the rexus ran away. And all these issues are now being corrected in a big time, because every month we have our head of the department, Dr. Madhushekhar sir, also here. We monitor these steps very carefully, so that we are, like Ashish said, we assess the trainees on a daily basis based on their intraoperative steps. We don't only take the posterior capsular rent or the zonal dialysis alone into account. We see how many buttonholes have happened, how many prematures have happened, how many people have their rexus run away, and how many of them have left their cortex behind before closing the case. And all those things are now drastically reduced, sir. And even the external trainees, like when we say external trainees, we have even surgeons from Tirunelveli Aravind, Pondicherry Aravind, and Chennai Aravind who are now currently practicing with us. And going back, they've given good inputs about the simulator. And the best part is they are able to do it alone. They're here only for a week time. With an experience of 40 cases, they come to us, 40 or less, and then when they go back, they're able to do it on their own.
So there was one question I wanted to ask. While performing the rexus, one of the commonest error the student makes is the loss of anterior chamber volume, because visco leaks out and the chamber shallows, and that's why the runoff occurs. But in this simulation, there is no question of losing the chamber.
Sir, I was going to add on to that what just Dr. Shivkumar and Dr. Shankar said. Simulation allows you the opportunity to work in a fixed anterior chamber, where the trainee in the initial phase of learning only learns about how to maneuver the cystitome or the utrata. But then once they are good with that, we add another component which is available. It's called a variable anterior chamber. So the chamber behaves exactly the way if you press on the floor of the tunnel, there is going to be visco leak and shallowing of the chamber, thereby leading to the rexus runout. You have the opportunity to inject more viscoelastic, cause chamber to deep, allow mydriasis, and continue with the rexus. So that amount of variation is allowed right now on the Help Me CI surgery simulator. This variability in anterior chamber makes the surgery dynamic, makes the surgery real life. Like I said, one scenario was sphincterotomy. There you can do sphincters, a little sphincterotomy, inject visco, make the chamber dilated, and continue with your surgery. Not just that, it allows you to just do one step for 100 times or like capsular rexus, but it also allows you to do everything in continuity, right? From making the scleral groove tunnel dissection right up till closing the case, editing the incision. So it's like doing a real life surgery, almost real life, real to real surgery, and doing it n number of times without worrying about having any complications.
And sir, I think one of the most important things is the learning the judgment of the rexus size versus the nucleus. And in this case, unless and until the rexus is of the adequate size, you cannot proceed on to a hydroprolapse. So they have to get it right. They have to get it right and have to get it complete. So that's quite tough.
That is the main important point, sir. Like Ashish told, it is continuous, but to put it in lame terms, if your groove is wrong, if your tunnel is wrong, that's the same tunnel you will continue till the end. That's the same rexus size you will continue till the end. So every time you complete a step, the machine validates you, but it will allow you to complete the step, and at the end it will score you out. What is the size of your groove? What is the size of your scleral lip, corneal lip? What is the size of your rexus? How is your wave? Has it passed? Did the nucleus prolapse? Did the delivery happen in one go? All these things will be scored, and all these scores are internally given based on the measurements and the book written by our founder, Dr. G. Nachar Madam. And these measurements are being put through with the help of Haripriya Madam, Shivakumar sir, and Adiyar sir. So these measurements are perfect. The surgeons, whenever we do it in the both side, the residents will come and say, "Sir, I did the tunnel very well. I did the rexus very well, but when I go to live surgery, I am unable to." But here they cannot say it that way. The simulator itself will say whether you are correct or wrong. So they don't need a trainer standing nearby. The simulator itself will say whether you have done it perfectly or not.
So just does it give real-time advice while they're doing this is too small, enlarge it a bit?
Yes, it does.
Or it gives only at the end of the surgery?
No, it will give you real-time alerts of there being some endothelial touch or the iris touch. It will also show that there is some pressure on the zonules, some amount of zonules have been broken, and you need to be careful going forward. So it gives these real-time alerts that come up on your screen while you look, so that you are more careful continuing forward.
Suppose the incision size is small or something like that, the trainee will have an opportunity to enlarge it, something like that, sir?
Yes, it will not sorry, Shankar, go on.
Sorry, sir. It will alert you, sir. It will not allow you to proceed on to the next step. It will make you come back, redo the step again. It will make sure that your measurements are perfect. Then only it will allow you to go to the next step.
Very nice. So one last question.
Yes, sir.
So how expensive is this system? Because see, today, as far as I know, trainees go to some established private centers which offer SICS and PECO. There are a lot of these centers across the country. So they operate on real patients and get their experience. So how expensive is this technology? Who absorbs the cost? Does the institute absorb it, or the students have to absorb it? Or?
So, sir, Help Me See is not into selling of simulators. Help Me See is an innovation-based training center. So we are in the business of training. We have training centers and we have partner institutes like Arvind and LV Prasad, where we position the simulators and we have an agreement. There is a cost to it. The founders, as Dr. Shivkumar mentioned, come from the flight safety training, and the entire cost, which runs into millions and millions of dollars, has already been absorbed by them. So now the cost is per training. There is support from industry as well for this training, and it is not much. It is on par with what students do, where they go to other centers for, say, SICS or PHECO training. So we have these arrangements right now. We have two simulators at Arvind Eye Hospital, Madurai, and we get internal as well as external training, and there is a cost to it. But rest assured, it's not about selling the machine, but it is about making it available to people who need it the most at a cost which is affordable to everyone.
Sir, regarding the training program, sir, in Aravind Madurai, Madhu sir is also here, sir. In Aravind Madurai, we have one program for 1 week, sir. That is for external trainees who want to do only simulation training. They will not be getting any live surgery experience, but the whole day we will have classes, ebook trainings, and there will be a person sitting with them for the first 3 days to guide them in using the simulator. And we will have regular classes for them. Even when they are in the simulator, they will be allowed to use view the ebook. There will be, once they the cost factor is something that I'm sorry, sir, that I don't know. Madhu sir may be able to enlighten it, but Once they pay, the trainees gets the access to the entire ebook. So even when they are not here with us, they can go back, log in that ID, and they'll be able to read the ebook on their phone. And something called the e-learning, what Dr. Ashish had mentioned, that's a very good tool, sir. For example, when they come to train with us, they will be validated in knowing what they know. The trainer will know what the trainee knows. Then based on that, we will be able to train them efficiently. So all our instructors have gone through this e-learning. So I will just ask Dr. Madhu sir to tell about this program, sir.
Nice talk by all the speakers. So it will be very useful for the this one audience. I think this is first time this type of program is there on training. So as in Arvind, we have this ongoing so many training program like for our internal fellows, PGs, and for external also. External will be for 1 month for PECO and SICS. And now recently we have started only simulation based training also. That is for one week. So that and this 1 week, as Shankar told, that they practice full day on simulator. And now we are getting only simulator trainees also, but few trainees who come for 1 month short-term training, they also, if they want to enroll in this short-term this simulator training, they are also getting benefited by that. And price-wise, we have kept it very less for this 1 week simulator training. It is 10,000 plus GST. So it comes around 13,000 for 1 week simulator training.
So apart from us at Tirunelveli, I think Aravind Pondicherry also sends the residents for training on the simulator. I would like Dr. Vivek to share his experience about how he feels this simulator is.
So good evening, everyone. An amazing talk by Shivakumar sir, my teacher, Ashish and Shankar. So we've just now started sending our fellows, and we are sending a few more residents in the coming weeks. And this one particular fellow was very, very happy doing that, and he definitely improved on his funnel and Rexes after the training process. So I just have to comment on one other thing, for PGs and residents, fellows in places where there is no simulator or the volume is low. What I have found helpful for them is the suturing. The maximum number of sutures they put, try to put radial sutures. This has definitely improved their hand-eye coordination, usage of the microscope, focusing. All this has improved, which reflects during the surgical training. So we have a few examples of people who were really, really struggling, but with just suturing, they really improved. They started understanding better. That is the basic tool that we have in places where there are no other simulator or a wet lab or goat's eye or volume is where volumes are low. I think suturing is one wonderful technique to improve the surgical skill also. Shivakumar sir, your take on this?
What about you got some camera and you will be watching the surgery from outside and you will be giving a real-time comment about the surgery or something like that?
Yes, sir. We are doing that, but it is better off when a post-surgery analysis for discussion. A video recording is definitely helpful. You can pinpoint. They are pressing too much on the sclera. They're pulling the eye too much, which is causing shallowing or all that. So those points, it is really definitely a video recorded based training is more helpful for residents and fellows. You can pinpoint what they are doing wrong and how to do it better. You can show better videos. So that we do regularly in Pondicherry.
I agree with Dr. Vivek that the basic wet lab training has to start with suturing practice, because in cataract surgery, that is probably the only step, maybe phaco and chopping. But even then, there you can move only one hand at a time. But it is only in suturing where both hands have to move at the same time. And that hand-eye coordination development is at its best when you are doing a suturing practice. So my instruction to anyone who is struggling with surgery is to go back to the lab and put in as many sutures as possible so that their hands become steady. So, I mean, it goes a long way in improving surgeries. So those who really spend time doing this, I think, fare very well in their surgery and learning very well.
What about depth perception, sir? Is that also, I mean, we get a feel of depth also with the simulator?
Yes, we definitely get a depth perception. Definitely get a depth.
We get both the angle and the depth being analyzed, sir. They call it as training tools, but I call it as guiding tools. So they have both the boxes. When you do the tunnel, once the crescent touches the globe, you have a depth box as well as an angle box. So when in the depth box, if you go superficial, as we know, we go in the buttonhole. When we go too deep, we go with the premature. But when you replay the video, we can show the training exactly. The angle also was wrong, that the depth was also wrong. So the simulator has both of it analyzed at the real time.
With regards to repetition, is that also something like, is there a consumable or something, sir, per case, or it's just they can do n number of times and
we can do n number of times in a day, 100 times, 1,000 times. There is no consumable around it. In fact, it's complete virtual reality and haptic feedback system. So it is, you do as many as you want in a day, in a week's time.
Dr. Ashish, if some institution wants to get hold of the simulator or some private corporates or somebody for training, then how do they get hold of it?
So we have this identification of partner institutes where we have a minimum number of residents that is required, at least numbers in excess of hundreds annually to train, and there is a cost sharing model. So I can share those details with you, and depending on case per case basis, because there is just a limited number of simulators that we have now. Soon many more will be coming, but the idea is to have it at the right place so that many people can get benefited, and that center acts like a zonal center to attract trainees from regional peripheral centers. So yes, we have that model, and it depends on the number of trainees that can be supported for the system to work.
So the learning curve for this simulation-based training is very easy or complicated?
We have to say, for example, I can give Shankar's example. I'm so sure he's smiling with the number of surgeries that he has already done. And when he came down to Mumbai, and I was given the daunting task of having Shankar experience the simulation, there is a learning curve for people who already are into training, but for novice surgeons, right from hand holding to holding the instruments correctly, because they mimic real life, even the depth or the girth of the instrument that we show is the same, the movements that they learn. There is a nice learning curve, but at the end of that learning curve, the trainee becomes proficient. And we have this proven, we have a paper published in association with Shankar Netralaya LV Prasad and Mahatma Hospital Nagpur, where we had two batches. One who underwent simulation-based training and followed by live surgical training, and the other went through a traditional training followed by live surgical training. Each did 10 cases after their simulation-based training, which were monitored. So the simulation-based training did almost 45% less complications as compared to trainees who did not undergo simulation-based training. So there is this benefit of the simulation-based training that has been proven. There is a small learning curve, but the curve is significant enough for you to become proficient early and maintain that level of proficiency.
But there's a simple question. Suppose if I want to alter the shape of the people, I want to do a small people get trained in that. Is it possible to do this?
Yes, sir. And we call them the surgical variations, not just the pupil. We can change the cataract type also. We can have an NS2 grade. We can have a dense PSC. We can have a shallow anterior chamber to begin with. And you will be very happy to know that we are working on a trabeculectomy model with your help, so that you can also work in a CACG or a PACG model. So yes, these variations are there on the Cataract M6 platform, and we are going to add variations on the other surgical procedures as well.
That's great.
Thank you, sir.
And you were telling them that if you are coming with the FACO and suturing, everything, whether we can, same machine we can incorporate, or you have to be a separate.
Sir, same simulator, the software will be installed overnight and you will be able to take it forward. So we call it as a simulation platform now, because it is able to support everything right from FACO. Very soon we will be talking about glaucoma, drainage devices, implantation as well. So there is a lot of scope on this Help Me See Eye Surgery simulator platform.
They are all live connected, sir. Like for example, every day they monitor the trainees in China, India, in Mexico, and US. Sitting in Mumbai, they will be able to analyze everyone's performance, and they're giving us a hard time because as trainers, they expect our trainees also to do 100 times. To answer Dr. Atik's question, every trainee needs to do their tunnels, their X's, every particular step 100 times, and also the continuous module, a module which doesn't have any guiding tool, that also the trainee needs to do successfully. That is when they consider the training, the instructor and the training institute also effective in their process. So they're, to add on to that part of assessment, they are assessing even the trainer also here. So they're like very closely monitoring us.
I think this is a very exciting technology, and I think it should be available to all our students, because I think throwing the student on to a real patient to do his first case is, devaluing human life a bit. So I think that this going through a virtual training platform should be the first step in any training situation. In India, it's already now abroad. They always go through virtual training before they are actually put on real patients. But here, I think we are directly doing on real life patients, which I don't think is acceptable. So they develop some level of expertise and skill, and then they are put on real life patients where they would be expected to create far less complications and much better outcomes. So I hope this technology is available throughout on all platforms, and that would benefit all the students.
Just one small thing that I wanted to add, sir. A simulator in Madurai is not new. They had a FACO simulator previously, but I don't think it was put to so much use. I'm not sure, but at least at the times when this FACO simulator was there, our FACO trainees were not invited, or it wasn't used so prevalently as compared to what this one is being used now. So probably the feedback and the effect is much better with this simulator than the previous one. I don't know what's happened to that previous FACO simulator. Dr. Shankar can tell us.
One thing I want to add, sir, like that simulator what we were having, that FACO simulator, that agreement means expired. So they were asking so many means cost for that for renewal of agreement. So that was disposed. It was having both FACO and retina setup also for retina surgery also. And one more thing I want to add, that in Madurai we are having, Arvind Madurai, we are having both this means Help Me See simulator, but still we are having this wet labs. So it is not like that we are totally replacing this wet lab with simulator. So it will supplement to your training, wet lab training. So wet lab training is also parallel to this simulator training. So we are conducting both program. Like if trainees come for this one during their training period, they will practice both on course eye, wet lab, and then dry lab on simulator also. So this is not to totally replace that wet lab. It will supplement your this one.
And we would also like to announce, sir, that in coming October, we are having our second simulator SACS workshop in Madurai, sir. The last SACS simulator workshop we had in January, It was a very good reach out, sir. We had around 40 postgraduates coming from different medical colleges attending it for 2 days, sir. We had a very good input. There are people who have come back to us for training for 1 week and 10 days also. So this is going to happen in October, sir. I just would like to take this opportunity through TNOA, it might reach a much bigger audience. So I would just like to put it out in the crowd, sir.
Good. Thank you. Thank you.
Dr. Shiva, have you got any feedback from the students after they worked on the simulator? What do they have to say?
Yes.
What do the students mean?
Yes. They are more confident. They have said that they feel better. And I have seen them becoming independent much faster once they have been on the simulator. So far, I have sent about 6 residents, and they are doing quite well after returning from there. So actually, I thought that I should be letting them touch the human eye first. So after their basic wet lab training, I told them what the tunnel should be like, what the surgery is like. And after the tunnel, or even after all the steps were done, I sent them. And when they came back, they were actually, they became independent faster. I always take them through the steps. I take at least 10 cases for their tunnel to become perfect and then go ahead with the internal. And so at that stage, I had to send some of them. And when they came back, the internal part, if it was remaining, was much faster. Cortex wash was much faster. And those who had already learned these steps went there, perfected it there. And when they came back, I just had to be around to make sure that they didn't land into any trouble. But within 1 or 2 turns of 2 or 4 cases, they were fairly independent, and they used to call me only if they had any trouble. 4 of them at least have become independent after this simulator training. 2 of my PGs, a fresh batch with hardly any experience in surgery, have gone to the training now.
That's wonderful. Thank you, sir.
Thank you. Thank you so much. Any other questions? Any other suggestions, questions? But they were asking about the price.
So I responded there. So it's about
But
yeah.
I
it was Dr. Sharmila.
Okay, right.
And
in future, any plan to expand the increase in number of simulators?
Yes, sir. We will think about having more simulators depending on the output that we get from Arvind. So far, it has been a great journey with Arvind. We have had good training numbers in both internal and external, and we are very proud to announce that Arvind Eye Hospital Madurai has been very instrumental in helping us develop the FACO ebook as well, which gets launched today. So Shankar and his team have done a very tremendous job in helping us getting there. So the support from Arvind Eye Care System as such has been tremendous. I always lean back to you, sir, for glaucoma and pediatric cataract development as well. So it's a process. It has just begun, and we will need your support in development as well. So overall, it has been a very satisfying journey with Arvind.
We will work together, yeah.
And sir, no financial interest in this at all, but I'll put in a word for Dr. Bachao that for us consultants, for an opportunity to have a peep at this simulator, they are placed in most of the major conferences. And I think the upcoming CCC will definitely have this in Hyderabad LVPI.
Yes, it will be there.
Okay. Thank you, Bachao. Thank you, Sokumar, Venkatesh, Shankar, Madhu, Vivek. I think now the time to say vote of thanks. I request as the Chairman Dr. Atik to post vote of thanks. Welcome. Hiram Gopal, you are here.
Hiram, sir, you're muted.
Yeah.
Sorry, Atik's turn this time, sir.
Surgery பண்ணிட்டு வரீங்களா?
இல்ல சார், ஸ்க்ரப்ஸ்ல இருக்கேன். Hospital only in scrubs. Other conference work is going on around, sir.
Okay, yeah.
We got the agenda is finalized, sir. Conference agenda is finalized.
Great, great.
I will post it in the management committee after this meeting, and then we will release it, sir.
Okay, super, super. Do you have any question, final, last question?
No, sir, the question when I had was when the start of the session, like, is it possible to have these simulators instead of wet labs in conferences? Because not all institutions can have access to these simulators.
Yeah, that's what,
So,
yeah.
Is it possible that we can install, like, have something like a portable system, or is it possible to install it for 3 days, 4 days in a conference and then let PGs who are from the less fortunate institutions have access to these systems?
We do have presence at conferences. We do give a sneak peek, as we call demos, a little bit of hands-on to them, so that they can find the center closest to them and get the full week-long course. So yes, we do that in terms of demonstrations at various conferences. We were at AIOC. We will also be at, as sir mentioned, CCC conference at Chandigarh. So yes, we do have these sneak peeks and demos at conferences.
But I think
to participate in the annual TNOA conference also in August. We'd be proud to have you there.
But I think what Dr. Gopal wants is, Dr. Sriram wants is something like the SSTC that you have,
Yeah.
dedicated course like that.
Yes, we can support that as well, depending on how many trainees and how long the course duration is. With the training operations team, we can discuss and get back. Yes, we do support this.
Okay.
Okay. Okay. That's great.
And I'll kindly request RK sir to arrange it for the conference.
Yeah.
I'll push the ball to his court then.
It's a paid course or it's free?
It will be a paid course, sir.
Okay, Pastor, that yeah. Okay. Is it the time in August? Is it possible to?
Sir, I cannot confirm anything at the moment, but I will call you and we can have a.
Okay, yeah. We know, yeah. If it is possible, sir, we will.
Yes, sir. We can even allocate a budget for it, sir. Not an issue, sir. We can even allocate a budget for it.
Okay, great. Yes, as is, yeah. Right. Yeah. Thank you.
Yes, sir.
Thank you very much. I think now yours.
Sir, before the vote of thanks, I also have a request, like Sriram sir. Shankar sir, you are saying that you're planning to do this training program in October. It's a request from TNOA without the president's permission. On his behalf, I am asking if it will be possible to work together with TNOA. We can maybe share this invite to all postgraduates, and we can get more people, and we can do it on a regular basis as part of TNOA ARC's program also, sir. We'll be happy to come. We have heads of all Aravind Institute here, Vivek, Madhu sir, Shiva sir. So if you can permit us, it will be great.
That is why we have put it in the platform, sir. That is why I use this platform to invite, sir. So even Madhu sir was not, I didn't tell Madhu sir also. I just opened it up so that we can reach to more audience through you. And regarding the clubbing together, Madhu sir and RK sir will discuss and get back to you, sir. But October it is open, sir. We are open for 2 days. We will have intense discussions. And the most important point here is for Venkatesh sir and Sriram sir is this workshop will be entirely conducted by fellows. Our fellows do the work. We just take the backstage. We help them do the work, but the presentations, the training, the teaching, everything, discussions, everything will be handled by our senior fellows who are just 8 months into fellowship. So that is the most interesting part, and they are the most attractive part in that the workshop.
Great, sir. Atik, if I can suggest something, because this webinar is being live streamed, I think we should take this discussion off this will again be online forever. So I think we'll take the discussion off this webinar. Sometime next week, Atik, if you can talk with Ashish and Shankar sir and Madhushekar and see if we can, on evening, we can have a Zoom meeting and see how exactly we can go ahead with this, with the permission of the current and the incoming president. we'll probably brainstorm and see how we can go ahead with this. We'll take it off the live screened webinar at least. We'll take this screen off this webinar.
Yes, sir.
And, a request to Dr. Vivek, you should get your newest scleral fixation techniques also to this, Dr. Vivek.
Sure, sir, sure. As soon as Shankar and Ashish accept it, we will do it soon.
So thank you so much. This was literally like watching iRobot movie. I even in my dreams never thought that one day this will be reality. This is amazing, and the feedback on live training given by Dr. Shankar, Madhu sir, and Shivakumar sir, it's really amazing. Now it is actually scary. The gap between the so-called senior surgeons and the fellows will be caught up early, and we may have to retire early. So that I feel is the flip side of this technology coming in.
I have not told you one more thing, sir. One of our MLOPs is very good in simulator, much better than our trainers. She does all the steps on her own without our guidance. And I am really worried about that part.
So thank you. So thank you, RK sir. This was
praying like the doll. Yeah. Yes. Yeah.
Thank you, RK sir. This was a out of the box webinar. I personally enjoyed it a lot, and for first time at least I listened to every talk glued in. So this was really nice, wonderful discussions. Thank you, Shivakumar sir, for opening the Pandora's box and actually letting us know where the current postgraduates are. And heartfelt thanks and best wishes to Dr. Ashish, and wish you could continue this noble work of getting the next generation in tune. So this is really amazing work. Glad you took up this challenge, and you've made it practically useful and wonderful. Thanks, Dr. Shankar, for sharing your personal experience on this instrument. Amazing discussions as usual. I'm a big fan of Venkatesh sir's YouTube channel and his surgeries. So thank you so much, sir. Thank you, Dr. Vivek, and thank you, Madhu sir. Special thanks to our beloved President RK sir for this wonderful session. Thanks to Auro Lab for sponsoring this meet, and thanks to
sponsoring.
Yes, sir. And another request here, we request you to continue next year also.
No, I don't know.
So thank you so much, everyone. Hope to have another session. Maybe we'll have another one soon. This technology should reach postgraduates, and they should really benefit from this. At least people should be aware that such a system is existing. More people should visit this, is what I personally feel. Thank you so much, everyone.
Thank you.
Thank you, sir. Thank you, sir. Thank you.
Thank you, everybody.
Yes, doctor.
Thank you. Thank you very much.